Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 454 of our pharmacotherapy series, which majors in pediatric malignancies. The first case reads, HLK is a 2-year-old girl with a 3-month history of constipation and progressive abdominal distension. She has a decreased appetite, 1-week history of vomiting, and she is pale and tired. She has a large retroperitoneal mass and multiple bilateral enlarged inguinal lymph nodes. Her WBC count, differential and platelets are within normal limits. Serum sodium, potassium, chloride, creatinine, and glucose are within normal limits. Her laboratory test results also include the following: a hemoglobin of 5.1 grams per deciliter. The normal range is 11 to 14 grams per deciliter. A lactate dehydrogenase of 424 units per liter. Albumin of 2.3 grams per deciliter. A urine HVA of 570 mg per gram of creatinine. The normal range is less than 26 mg per gram. A urine VMA of 31 mg per gram of creatinine. The normal range is less than 11 mg per gram. Biopsies of the abdominal mass and bone marrow are positive for neuroblastoma cells that are MYCN amplified. The lymph nodes are negative for neuroblastoma. Scans are negative for other sites of disease. So my first question to you reads: which of these signs, symptoms, and laboratory results are consistent with a diagnosis of neuroblastoma? Virtually all of HLK's findings are consistent with neuroblastoma. The low hemoglobin and albumin and high lactate dehydrogenase, however, are not specific for this cancer. In addition to the biopsy, the elevated urine VMA and HVA are most helpful in confirming the diagnosis of neuroblastoma. In HLK, biopsies of the bone marrow, lymph nodes, and primary tumor were necessary to demonstrate the presence or absence of neuroblastoma at more than one site for staging purposes. My next questions to you read: what stage of disease does HLK have? What treatment will she receive? HLK's abdominal disease with distant bone marrow involvement indicates stage 4, or M, disease. Considering her age and disease stage, HLK has a high risk of dying from her disease. Her MYCN also was amplified. Therefore, she is started on chemotherapy consisting of vincristine, doxorubicin, and cyclophosphamide for cycles 1, 2, 4, and 6, and cisplatin and etoposide for cycles 3 and 5. HLK is 81.5 cm tall, weighs 11.65 kg, and has a body surface area of 0.5 meters squared. For her third chemotherapy cycle, consisting of cisplatin 50 mg per meter squared per day on days 1 through 4 and etoposide 200 mg per meter squared per day on days 1 through 3, she is given hydration fluids of 5% dextrose with 0.45% sodium chloride at 62.5 ml per hour. Urine output is 4 ml per kilogram per hour. So my next question to you reads: how does monitoring of HLK's chemotherapy differ from that of an adult? We will begin with monitoring vital signs for etoposide. Although prevention and monitoring of toxicities from chemotherapy agents in children follow the same basic rules as in adults, there are some differences. When monitoring vital signs for hypotensive reactions to etoposide, normal blood pressure will be lower. Hypotension is defined as a systolic blood pressure under 74 mm of mercury for a 2-year-old girl, and the pulse higher, mean 119 beats per minute for a 2-year-old, than in adults. It is important to have baseline vital signs so that hypotension or tachycardia will be recognized. Next we will look at monitoring hydration for cisplatin. In adults receiving cisplatin, hydration is often standardized with 1 to 2 liters of intravenous fluids given before the drug, 1 to 2 liters with the drug, and then continuous hydration for at least 24 hours after the dose. In children, hydration volumes should be calculated based on the child's size. To decrease the risk of cisplatin nephrotoxicity, most pediatric protocols recommend IV fluids at twice maintenance rates to maintain urine outputs of at least 2 to 3 ml per kilogram per hour. The COG calculates maintenance fluids as 1,500 ml per meter squared in 24 hours, so HLK should receive 3,000 ml per meter squared, which is equal to 1,500 ml during 24 hours, running at 62.5 ml per hour. HLK's measured urine output is 4 ml per kilogram per hour, which should be adequate to prevent nephrotoxicity. Weight should also be monitored throughout cisplatin administration to assure fluid balance. Acute weight gain may require diuretics to prevent overhydration, and weight loss may indicate dehydration with impending reduction of urine output that could lead to acute nephrotoxicity. Increased IV fluids would help prevent the latter. HLK's measured creatinine clearance is 39 ml per minute. So my question to you reads: should her cisplatin be withheld or the dose adjusted because of low creatinine clearance? Cisplatin is either not administered or administered at a reduced dosage when the creatinine clearance is less than 50 to 60 ml per minute per 1.73 meters squared. Although HLK's creatinine clearance of 39 ml per minute appears to be low, it is relative to the patient's size, i.e., 39 ml per minute per 0.5 meters squared. Guidelines for dosing drugs cleared by glomerular filtration are based on creatinine clearance for normal adult body size, that is 1.73 meters squared. Therefore, it is important to correct HLK's creatinine clearance to adult body size. Multiplying by 1.73 divided by 0.5, Her creatinine clearance is 135 milliliters per minute per 1.73 meters squared. So this is not a reason to withhold cisplatin. One precaution is that the accuracy of serum creatinine and creatinine clearance in assessing renal function during cisplatin therapy in children has been questioned. HLK obtains a partial response to the aforementioned initial chemotherapy regimen with reduction of urine VMA and HVA concentrations and a 50% decrease in the size of the primary tumor in the abdomen. Second-look surgery is performed to debulk the tumor, and pathology results indicate that the residual tumor contains 95% mature, that is benign, ganglioneuroma cells, but neuroblastoma cells are still present. So my question to you reads: what further treatment has the most potential benefit for HLK? The best chance for prolonged disease-free survival for HLK is dose-intensive chemotherapy combined with autologous peripheral blood progenitor cell rescue. The regimen she is receiving was designed to be followed by high-dose chemotherapy and stem cell rescue. The 2 to 3 year disease-free survival is better with high-dose chemotherapy followed by autologous progenitor cell rescue. The plan for HLK is to proceed to high-dose chemotherapy, carboplatin, etoposide, and melphalan, with an autologous progenitor cell rescue. If a complete response is achieved, she would then receive radiation to the bed of the primary tumor, followed by 6 monthly cycles of isotretinoin, that is cis-retinoic acid, and 5 cycles of dinutuximab with granulocyte macrophage colony stimulating factor during cycles 1, 3, 5, and interleukin-2, during cycles 2 and 4. All 3 of these treatments, dose-intensive chemotherapy with progenitor cell rescue, isotretinoin, and the dinutuximab regimen, have been shown to independently increase survival. Next we will look at further treatments based on disease biology. With rapid advances in neuroblastoma biology being made, future alternatives may include more biologic treatments. One agent in clinical trials is 131-IMIBG, a compound that delivers radiation directly to catecholamine-secreting cells such as neuroblastoma. Studies have used 131-IMIBG as part of the conditioning regimen before progenitor cell rescue in patients with neuroblastoma. Crizotinib, an anaplastic lymphoma kinase receptor tyrosine kinase inhibitor, has entered phase 1 to 2 clinical trials in pediatric patients and shows some promise for a small percentage of patients with neuroblastoma. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 455.